We are live. Dr. Riya, we are live.
Okay. Good evening, ma'am. Good evening, everyone. Today I'm doing a case presentation of proptosis. I am Dr. Riya, a DNB student at Sankara Eye Hospital, Guntur. I'm doing this case presentation under the moderation of Dr.Sirisha ma'am, who is an oculoplastic consultant at Sankara Eye Hospital, Hyderabad, and Dr.Sowjanya ma'am, who is an oculoplastic consultant in a Sankara Eye Hospital, Guntur. Shall I start, ma'am?
Yes, proceed, Riya.
So I'm presenting a case of 41-year female who works as a homemaker residing in Prakasham district, Andhra Pradesh, came with a chief complaint of forward protrusion of left eye since 1 month, and diminution of vision in left eye since 1 month. So history of presenting illness. Patient was apparently all right 1 month back when she noticed outward protrusion of left eye, which was insidious in onset, gradually progressive and painless in nature. It was associated with simultaneous diminution of vision in left eye since 1 month, which was insidious in onset, progressive in nature, and she did not notice any defective vision in left eye before 1 month. There was no history of double vision, pain, redness, watering, or discharge, photophobia. There was no history of ocular trauma or surgery. There was no history of similar episodes in the past. The protrusion of eye, there is no variation with the change in the posture or with coughing or sneezing. She did not have any history of fever, headache, sinusitis, no history of resting tremors, palpitation, heat and cold intolerance, fatigue, muscle cramps, and neck swelling. She also did not have any history of anorexia, weight loss, any malignancy of eye, orbit, or body. Family history, it is not significant. Past history, there is no history of similar episodes in the past. She is also not a known case of diabetes, hypertension, thyroid, any heart problem, malignancy, or tuberculosis. She did not had any surgery for any tumor, radiotherapy, or chemotherapy in the past. She is not aware of any allergy. Personal history, she consumes a mixed diet, normal appetite, and bowel and bladder habits are normal, and she did not have any habits. General examination. Patient was moderately built and well nourished, conscious, cooperative, and well oriented to time, place, and person. Her vitals were within normal limits. General physical examination. There was no pallor, edema, cyanosis, clubbing, lymphadenopathy, icterus. There was no swelling in the neck. Systemic examination, per abdominal examination, it was soft and there was no organomegaly or any palpable mass was noted. Cardiovascular system, respiratory system, and central nervous system were within normal limits. Ocular examination. Visual acuity, unaided visual acuity in right eye was 6.9, which improved to 6.6 with pinhole. And in left eye, it was 3/60, which improved to 4/60 with pinhole. Near vision in right eye was N6, and in left eye, it was N60. Color vision in right eye was normal, and in left eye, it was decreased to 3/21. Intraocular pressure in right eye was 15 and left eye 18. Ocular examination. On inspection, the head posture was erect. Facial and ocular symmetry was not maintained due to left eye proptosis. So, evaluation of proptosis. Inspection, there was a noted proptosis in the left eye and down and inward dystopia. The eyelids, there was no ptosis, no lid retraction or lid edema. There was fullness in the superior temporal region of the orbit. There was no sign of any periorbital inflammation. No, there was no visible scar, fistula, redness. Dilated vessels was not noted over the swelling. The size of the swelling did not increase with the valsalva. Bell's phenomena was good, and there was no leg ophthalmos. Extraocular movements were full and free in all gazes. Uh, yeah, so it was normal. Extraocular movements were normal in all the gazes. So now confirming the inspection findings by palpation. The Bony orbital rim was intact. Finger insinuation was not possible in the superior temporal orbit. Superior temporal part, rest all it was possible. Firm non-tender mass was felt in a superior temporal part of the orbit, whose anterior margin was palpable between the globe and a bony rim, and the posterior end was not felt. So we can say it is extending into the orbit. The anterior surface was about the size of 10 millimeter by 3 millimeter. Surface was regular and it was not adherent to the overlying skin. And adherence to the bone could not be assessed. There was no color change or raised temperature of the skin over the mass. On retropulsion test, there was mild resistance noted. There was no pulsation, no thrill was felt, and the mass did not enlarge. Sorry, there was no enlargement of the any lymph node, regional lymph node, preauricular and submandibular. On auscultation, there was no bruise. On exophthalmometry done with the Hertel's exophthalmometer, the baseline was 105 millimeter when the right eye was 20 millimeter and left eye 23 millimeter. So there was a difference of 3 millimeter. And dystropia, which is the horizontal dystropia, in right eye it was 26 millimeter and left eye 22 millimeter, and vertical right eye 2 millimeter and 4 millimeter in left eye. So we can say as compared to the right eye, there was in left eye, there is 3 millimeter proptosis with dystropia of 4 millimeter inward and 2 millimeter downward. So anterior segment examination in right eye, the eyelids were normal, rhoplus was negative, conjunctiva is normal, cornea was clear, normal in size and shape, anterior chamber, it was normal in depth. Iris, there was normal color and pattern. Pupil was central, regular, round, and reacting to direct and consensual light reflex. In lens, there was nuclear sclerosis, grade 1. Anterior vitreous was clear. And in left eye, the eyelids were normal, rhoplus was negative, conjunctiva was normal, cornea was clear, normal in size and shape. Anterior chamber was normal in depth. Iris had normal color and pattern. Pupil was central, round, regular, reacting to direct and consensual light reflex, but there was grade 1 RAPD noted in the left eye on swinging test light. And lens, there was early cataractous changes, that is nuclear sclerosis of grade 1, and anterior vitreous was clear. Fundus examination in a right eye, media was clear, disc was normal in size, round, and pinkish in color with well-defined margin. Cup is to disc ratio was 0.3:1 with a healthy neuroretinal rim. Blood vessels were normal with AV ratio maintained of 2:3. Background was normal, macula was within normal limit, foveal reflex was dull. In left eye, media was clear, disc was normal in size, round and pinkish in color with ill-defined margins, and the cup is to disc ratio was 0.3:1 with healthy neuroretinal rim. Blood vessels were normal with AV ratio of 2:3 maintained. Background, there were ILM folds and choroidal folds in the posterior pole area, and there was an inward bulging in the superotemporal quadrant. And macula, there was a foveal scarring noted. This is the diagrammatic representation of the same. So my provisional diagnosis is both eye early lenticular changes with left eye abaxial proptosis.
Can you summarize the case before going to the provisional diagnosis?
Yeah. The 41-year-old female came with a complaint of diminution of vision and forward protrusion of the eye since 1 month. She did not have any significant past history about any malignancy or any trauma or surgery. And on anterior segment, there was a RAPD noted in the left eye of grade 1. And posterior segment examination, there was a choroidal folds and macular scarring and inward indentation of the globe. And there was a mass noted in the supratemporal orbit, which was formed, and only anterior surface could be palpated, which was regular, and it was not there was no any overlying changes in the skin, or it was not attached to the skin as well.
Okay. So what is your clinical diagnosis?
So there is a abaxial proptosis in the infranasal direction, secondary to the mass in the supratemporal orbit, along with the mass effect on the globe.
So probably.
So probably it would be a lacrimal gland mass. It can be either benign or malignant.
Okay.
Usually,
Okay. So what else other than lacrimal gland?
other
Based
than
on the anatomical location.
that, it can be dermoid cyst as well sometimes. Or any infiltration secondary to any sarcoidosis or Wegener's granulomatosis in the lacrimal
How
gland.
does it usually present? Is it most commonly bilateral or unilateral?
It is bilateral, ma'am. This is unilateral.
And what other typical finding you see in Wegener's granulomatosis? Which is the most commonly affected part in Wegener's granulomatosis systemically?
Salivary glands usually will be affected.
Wegener's? Nose. Nose is the most common.
Okay, I don't know, ma'am, then.
And then there's widening of the nasal bridge along with the orbital inflammation. That gives you a clue that it is a Wegener's granulomatosis.
Okay.
And it is more commonly bilateral. Okay. What other can it be? If the patient had, see, your patient had only 1 month history, right? So
Yes,
do you think that is that short duration of history, where does it lead you to?
it can be an acute onset dacryoadenitis as well.
Okay.
But it is usually associated with the redness or any pain, but she did not complain of any pain.
Okay. And which other tumor you can consider with pain? Is it only inflammatory?
No, ma'am. Adenocystic carcinoma is usually associated with the pain due to its perineural spread.
Very good.
So that can be there.
Okay. And what else can be?
Any metastatic tumor.
So which tumors cause metastasis?
Breast cancer is most common in the female. Lung cancer.
And in the breast in this case?
I did not, ma'am, but I asked.
You forgot about the nasal examination too. Nasal and oral examination is mandatory because primary direct spread through the adjacent structures is more common, right?
Okay, yes, ma'am.
Okay. And okay, proceed.
The patient is she doesn't know since the duration of the symptoms. You can ask the old photographs of the patient, what's called FAT scan, family tomography scan. So if you look at the old photographs, we know the duration of the disease. So patient might have noticed since 1 month, but it might not be the duration. So if you can ask the old photographs, and you can just look at the old photographs to know the duration of the disease. Okay.
Okay, ma'am.
And what is the cause of vision, loss of vision in this patient? What could be the reason?
Usually in the proptosis case, in this case, there is a globe compression, ma'am, and there is a macular scarring as well. So both can contribute to the diminution of vision.
And normally, what are the reasons for loss of vision in the case of proptosis?
Optic nerve involvement, like tumor involving optic nerve, like glioma or meningioma, or any tumor compressing the optic nerve can also cause. Exposure keratopathy can cause. Or
What
globe
else?
compression.
Of thyroid eye disease.
Yes, ma'am.
Which is the most common cause of proptosis, unilateral or bilateral?
Thyroid, ma'am.
what is the reason for vision loss in thyroid eye disease? Can thyroid eye disease present
ma'am.
vision loss?
Yes, ma'am.
What is the cause?
Optic nerve compression or exposure keratopathy, both can contribute.
Yes. So what is your probable diagnosis here?
Here,
What is your first?
pleomorphic adenoma, I would think, or here, ma'am.
See, pleomorphic adenoma is a histopathological diagnosis that you will know only once you do surgery, excise the mass and send it for a biopsy, right?
Okay.
You should always talk about clinical diagnosis.
Clinical.
See, in exam, everybody knows you know the diagnosis, but you have to be very careful of what comes out of your mouth.
Okay, ma'am.
Okay,
Benign.
so till here, you should think about what clinical signs you have seen. Okay.
Lacrimal gland tumor.
Yes. Okay.
Benign or malignant.
Yes, it could be a dermoid too.
Dermoid.
Because of the anatomical location here, most common can be lacrimal gland because of the anatomical location and the dermoid, right? And what others it can be?
So, ma'am,
What are the other possible diagnoses? It can be a cavernous hemangioma. Hemangioma, schwannomas, neurofibromas can happen anywhere in the orbit, right? They are not specific to an anatomical location. So it can be that too. Most probably, this is a well-defined mass, so
yes,
you're probably thinking it's as a benign lesion, right?
yes,
Only the imaging will give us a clue. Yeah.
yes, ma'am.
Please proceed.
So, for this case, we'll proceed with investigation for confirmation, MRI to know the extent and surrounding tissue involvement, and OCT macula as there was a scarring in the macula. And after that, excision biopsy or histological confirmation of the tissue. So on MRI, there is in the left orbit, there is an extracornal, well-defined heterogeneous soft tissue mass in the supratemporal orbit with a proptosis and mass effect on the adjacent eyeball with indentation of an optic nerve at the optic nerve head. And extraocular muscles are normal.
Okay. So how is the mass? How is the lacrimal? How are the lacrimal glands? Is it the mass continuous with the lacrimal gland? Is there any bony scalloping? Because this is an MRI, there's no bony
Yes, ma'am.
delineation. Okay. So how will you come to a conclusion of what is the origin of this mass? See, you have defined the mass, but you have not defined where is it coming from.
Origin. Okay, ma'am.
In the first picture, can you make out the lacrimal gland? The
No,
right
ma'am.
side?
It's
Yes,
not visible.
not visible.
Like it is the mass is in the place of lacrimal gland where it should be there.
Okay.
So
Is
that is
continuation with it?
yeah, yes, ma'am.
See this. Come to the coronal view.
Okay, ma'am.
Sorry, axial sections.
Ah.
Can you see in the second image? Can
Yes,
you
ma'am.
see there's a lacrimal gland on the right side? Can you make out just beside the on the right side? The normal lacrimal gland is what I'm talking about.
Yes, ma'am.
And on the left side?
This one, ma'am?
Yes.
Yeah.
Continue. So you should be telling that it's probably arising from the lacrimal gland. Okay.
Okay.
Here we cannot comment on the bony window because CT is better when it comes to delineating the bone and also to look at the bony infiltration.
Yes.
That gives us a diagnosis whether it is benign or a malignant lesion. Okay.
So on OCT macula, there was a macular scarring noted. Same. Foveal counter was altered and there was a flattening, suggesting of atrophy and scarring.
No.
So, yeah, the treatment and the definitive diagnosis would be an excision of a mass with an biopsy by a lateral or superior orbitotomy, and the histological evaluation and conformation of an tissue cells.
Was the surgery done?
Yes, ma'am, it's done.
Okay. Does the histopathology report come?
It came as an pleomorphic adenoma.
Left cranial line.
This
Okay.
was the
So would your approach change if it was a malignant lesion? Till now? Anywhere?
if it is a malignant on surgical approach, we should spare some tissue, like normal tissue, along with the mass.
No. You didn't get me, I think.
Okay.
Would your surgical approach change if it was a malignant lesion? If you suspected a malignant lesion?
Surgery, like after surgery, if needed, and external beam radiation or chemotherapy would we will add along with the excision.
If it was if you suspect a malignant lesion, it always confirm it on a PET CT scan. Okay. And then if it is a malignant lesion, you usually take an incisional biopsy. Okay. You don't excise the tumor at a time because before giving radiation, how will you tell the patient, convince the patient whether it is a malignant or a benign tumor?
Yes.
You need histopathological evidence, right?
Yes, ma'am.
You usually take a biopsy and you should usually go through a direct subbrow incision and directly approach the mass and take a incisional biopsy. Okay. And then once it's malignant, if you either do chemo reduction and then go for the en bloc dissection along with the periosteum. Okay.
Yes, ma'am.
Yeah. So yeah. Okay. So can you go back? We'll discuss about each point because since we have time.
Yes, ma'am.
Go back to your history. Yeah. Next.
Yes.
Yes. So what all each negative history, can you elaborate? Why is it important in a proptosis case?
Yes, ma'am. History of double vision. That is, if there is any mass causing restriction of movements, it can cause a double vision. Or if any mass or any infiltration is there to the nerves,
Like
involving the nerves as well.
No. Okay. And then what is the most common condition where you expect double vision? Most common unilateral or bilateral?
Thyroid, ma'am. Thyroid orbitopathy.
Happens there. Why is there double vision there?
Restriction or restrictive.
Yes. Why is there restriction? What happens? What is the pathophysiology in thyroid?
There is inflammation of the muscles and orbital tissue as well.
Okay. Inflammation and infiltration.
Infiltration.
Both fatty infiltration and infiltration with glycosaminoglycans. Okay. So that is why there is swelling of the muscle, which later gets fibrosed in chronic cases, and it restricts.
Yes.
Okay.
Other than that, pain, redness, watering, and discharge to rule out if there is exposure keratopathy.
Okay, in thyroid, but other ones, pain and redness, what will it?
Pain, there any infective or inflammatory cause usually presents with the pain, or in case of adenocystic carcinoma also there is a perineural spread that can also present with pain. So for that.
Then what about trauma? Why is trauma significant?
Trauma, if there is any hematoma, emphysema, or that can also present as a proptosis.
Okay. What other post-trauma? What is the most common what happens where there is pulsatile proptosis?
Carotid cavernous fistula can occur.
It usually is post-trauma.
Yes.
Spontaneous also happens, but spontaneous is very rare. Okay. And then, why is surgery important?
Surgery, if previously any surgery for any mass she had underwent, or any for any tumor in the body also, if she had underwent.
Okay. Okay. Yes. Next slide.
So variation in the with a change in posture or with coughing and sneezing, it is to rule out orbital varices.
Okay.
History of fever, headache, or sinusitis. The sinusitis, there can be direct spread orbital cellulitis if it is there,
Okay.
and fever and headache also for orbital cellulitis, or cavernous sinus thrombosis also can present with proptosis secondary to that, fever and headache.
Okay.
And resting tremors, palpitation, heat. This all is for to rule out any thyroid, dysthyroidism, systemic findings.
Okay.
History of anorexia or weight loss. In case of malignancy, patient will have the signs, or any other malignancy of the body. Or
What is the most common malignant tumor that infiltrates the orbit in males? Females, it's
lung cancer, ma'am,
and
and prostate.
yeah. Next. Okay. So, why is thyroid and the thyroid is understood? Why is TB history important? History of TB.
Tuberculosis, like tuberculoma, can orbital tuberculoma can be there.
Okay. And why is diabetes important? Uncontrolled diabetes. What is the most common thing you see in orbit?
But,
Poor blood sugar controls, chronic diabetes. Recently, we had a wave of COVID. We have seen many
yes,
cases.
mucormycosis,
Yeah, so that is why
fungal
the
proptosis.
examination is mandatory. Okay. Yeah, next please. You can skip this. Okay. Now, can you elaborate on more on lacrimal gland tumors?
Okay. Like lacrimal gland tumors, it can be either benign or malignant. In benign, the most common one is pleomorphic adenoma, and in malignant type, it is adenocystic carcinoma is the most common.
So only tumors that happen in lacrimal gland lesions.
No, ma'am. In there can be myeloid. Sorry, I forgot my name.
The lacrimal gland tumors are usually divided into epithelial and non-epithelial. Okay, 50% of them are epithelial, 50% of them are non-epithelial.
Non-epithelial.
Okay. In epithelial, again, 50% are benign and 50% are malignant. And in that 50%, again, adenoid cystic carcinoma takes
50%.
is 50%. And then other carcinomas like adenocarcinoma and other mucoepidermoid carcinoma, all that are they all share a 50%. And in non-epithelial tumors, you have lymphoid variants like lymphomas and lymphoproliferative disorders, which constitute 50%. And then the other 50% is usually infective or inflammatory conditions. Okay. So, is there a chance of malignant transformation in pleomorphic adenoma?
Yes, ma'am. After excision, if there is any retention of the cyst, it can transfer into malignant type, or if not treated, also spontaneous transformation can be there sometimes. It causes the
So you should always remove it in total. Never allow any spillage. Okay. Sowjanya ma'am, do you have any
Yeah.
questions?
Riya, what is the bedside examination if there is a mild proptosis? What are the
yes, ma'am. There are two views which helps to assess the mild proptosis: Nepziger's view and Worm's view. In
how will yeah
In
proceed?
Nepziger's view, stand will be standing at the patient's head side and will see tangentially towards the chin and will tell the patient to tilt his head backward. So we'll see the prominence of an eyeball and compare it with the orbital rim. And in Worm's view, we'll see through the chin side. We'll tell the patient to look up and will stand in front of the patient and compare it with the other eye.
Yeah.
So Hortense, why is base reading important? You mentioned the base reading is 105, right?
Yes, ma'am.
Base reading important.
Like to avoid the parallax error on subsequent measurement.
It's not the parallax error, it is the intermeasurement error. So every time you put at the same base reading and check so that you can compare if the proptosis is increasing or decreasing. Here, obviously this tumor is going to be excised. But in case of thyroid, where you need the patient comes for repeated follow-ups, you have to check whether the proptosis is increasing or stable. Okay.
Yes,
So
ma'am.
that is when the baseline helps. Also, when you increase the baseline reading, the measurement also increases.
Yes, ma'am.
Okay. So to keep it constant and to avoid the intermeasurement errors, we keep the baseline standard. Whatever first you have seen, it
Yes.
is always you're supposed to see and look at adjust the hurdles at the same baseline and check.
Okay.
Yes. So what are the most common DDs of tumors that are in the superinasal quadrant? This is superotemporal, right? What are the
Yes, ma'am.
common causes in superinasal quadrant?
There also dermoid can be the one.
Before
Or
dermoid, what is the most common thing?
ethmoid meningocele.
Meningocele. Directly.
Mu-
Like
is it still or mu-
Mucocele. Ethmoid or frontoethmoidal mucocele, not
mucosal.
meningocele.
Okay.
Okay, meningocele is like brain protruding out. Okay. So if there is an inferior orbital mass, what would be the most common?
Maxillary sinus carcinoma, or there can be lymphoma.
Okay. What is Salmon patch, Leah?
It's a subconjunctival lymphoma.
Okay. How does it appear?
um, or a pinkish color, and it will be firm in consistency. Uh,
And usually it follows the contour of the globe. Usually all lymphomas follow the contour of the globe.
You mentioned about pulsations, right, Riya? How will we check for pulsations?
it's like we'll place the two fingers on the eyeball, and there are like direct transmission, or sorry, direct pulsation or transmitted pulsation. We'll see the movement of the finger. If it is just raising, it's transmitted. If it raises and it moves apart as well, it is direct. Sirsha ma'am, your voice.
Yeah. Can you tell me some common causes of pseudoproptosis. What is pseudoproptosis and can you elaborate on it?
Okay. Pseudoproptosis is like not as such proptosis, but eye appears to protrude out. The in case of ophthalmos or myopia or contralateral ptosis in ophthalmos.
Okay. And ipsilateral eyelid retraction.
Yes, eyelid retraction. Shallow orbit as well.
Yes. Shallow orbits is usually bilateral.
So how do you manage this patient, Riya?
This patient, excision of the tumor.
Okay, what is the approach?
Here, superior or lateral orbitotomy can be done, or anterior orbitotomy through superior incision, like superior lead crease incision, or lateral orbitotomy.
So let crease incision and in toto excision of the
In
mass.
toto excision.
So we'll try to prevent breach of the, this is a pseudo capsule or pseudo. We'll try to prevent the breaching of the capsule. And is there any role of incision biopsy in these type of lesions?
Usually, no, ma'am. Like to prevent seeding, it can cause.
Yeah. So preferably we'll go for an excision biopsy. When there is a diagnostic dilemma, maybe. But it's an well encapsulated lesion. Excision biopsy is the choice of management. And what is the follow-up? Like in total, you have done, there is no breach. So what is the likely chance of transformation to the malignancy and how far we need to follow these patients? Is there any chance of turning into malignancy?
If there is no breach or no seeding, there is very less likely chance of a malignant transformation. But if it is there, then there are high chances of malignant transformation.
Yeah, the restage recurrence rate is approximately 30% over 5 years period. So we need to have a close follow-up on these patients. And how will we differentiate radiologically from a pleomorphic adenoma with adenoid cystic carcinoma? Radiologically differentiate.
Okay, ma'am. Bony erosions will be there in carcinoma,
Okay.
but in pleomorphic adenoma, which is a benign lesion, there will be no bony erosion. Indentation can be there, but erosion will not be there. Destruction.
Patient is on globe.
No. Okay. Bony indentation.
Bony remodeling will be there because if any long-standing masses will cause bony remodeling, benign lesions. Bony destruction or erosion will be seen in a malignant lesion. Okay? Bony remodeling will be there in a benign lesions. Yeah. So usually pleomorphic adenoma, it's well-defined, round or oval. Calcification may or may not be seen with bony remodeling. Adenoid cystic carcinomas usually will have an irregular margins.
Yes.
Calcification, bony destruction, erosions, and nodular.
Calcification will be more in carcinoma, ma'am. Like, is it like?
Yeah. Did you mention about shimmers in this patient?
No, ma'am.
It's good if we do shimmer so that we can measure the tear film. Okay, because after surgery, definitely because we are removing the lacrimal gland, so there will be chance of dry eye. So we can shimmers if you do better. Okay. Anything need to be added, Dr. Sirisha?
I think that's it, ma'am. I'm just trying to get some more questions because I think we still have time. So can you tell about differences between CT and MRI, Dr. Riya? Can you elaborate a bit on the advantages and disadvantages of one over the other?
CT scan is usually it delineates the bony abnormality. Like in this case also, if there is bony erosion or bony involvement, it's better seen in the CT scan. And for soft tissue details, MRI is the choice.
Yes. And also, the risk of radiation is there in CT,
In CT
that
scan.
is not there in MRI.
Yes.
And in trauma, CT is more preferable than MRI. Okay,
Yes.
because of the bony landmark, the details of the bony landmarks. Okay, and also patients who are claustrophobic, MRI may not be suitable for them.
Okay, yes, ma'am.
But there CT has an advantage because it is a quick procedure. Whereas MRI, the patient has to lie down for half an hour inside a closed chamber.
Yes, yes, ma'am.
And also patients who have implants,
Mm-hmm.
then you have to be careful. Because MRI is a strong magnet and it is not, it is contraindicated. Okay. That's it from my side, ma'am.
Nice presentation, Riya.
If you have any doubts, you can ask Dr. Riya. Or if the audience has any doubts, if there's anybody is watching.
There's nothing as of now, ma'am. If there is anything, I'll let you know later.
Sure.
If it is done, then we can end the meeting.
Okay.
Thank you so much.
Very well presented, Dr. Riya.
Thank you, ma'am.
I only wanted to keep in mind that when the examiner asks you about diagnosis, don't give a histopathological diagnosis. Okay?
Yes, yes, ma'am.
Based on whatever you have done, okay? Whenever you write a case sheet, go through it, and then only based on that, you give your diagnosis. Even though you know about the case, you have to give only a clinical diagnosis always.
Yes, ma'am. Okay, ma'am.
Always should be a clinical diagnosis. Okay. Never, it should not be a histopathological. Diagnosis can be clinical, radiological, and histopathological.
Okay, ma'am.
The orbit is like a Pandora's box. Nobody knows what it is until and unless the biopsy report is out.
Okay, ma'am.
So they expect what is the examiner, what they see is how good are your clinical skills, your examination skills, and your history taking. Okay. Nobody will be expecting a definitive diagnosis from you because even we cannot diagnose this until the histopathological report is out. Okay. So your clinical acumen should be good. I think you did a great job.